Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with the masterclass series on medical disorder and ART pregnancy, which is organized by Indian Fertility Society, UP Chapter East. And today is the episode number 3. And the topic of today's episode is APLA and pregnancy. So let me introduce our speaker, Dr. Manjusha, ma'am.
Thank you, Nishanji.
1 minute, ma'am. Let me introduce.
Please, we can
Sure.
skip the formalities. Can we skip the formalities?
Let me give a little introduction.
We can skip the
So,
formalities. We all know each other. Thank you.
okay, ma'am. Thank you, ma'am.
Okay. Thank you, Nishanji, for providing us this platform. Thank you, Shield Pharma. And this masterclass series was the brainchild of our revered Sundravati ma'am, Nita Das ma'am, Uma Singh ma'am, and we decided to continue with this mode of learning even beyond COVID era. And this helps us connect people from far and wide, which is really a blessing. So this is the third episode, and today we are going to talk about the topic which intrigues all of us, the antiphospholipid antibody syndrome. So we have a galaxy of very eminent speakers and experts and panelists with us today. And I would request Dr. Vaida to take forward the event of the day. Thank you.
Thank you, ma'am. Thank you, ma'am. So nice of you. And I guess your voice is breaking a little. My voice is audible.
Yes.
Okay, thank you. So respected seniors, respected delegates who have joined us, friends and colleagues, I welcome you all in this webinar on antiphospholipid antibody syndrome and pregnancy, which is, as already told by Nishanji, is the master class series on medical disorders and ART pregnancy, and it is the third episode on it. So we have with us stalwarts from both the obs and gynae and the immunology domain. And to name it, I welcome Dr. Uma Singh ma'am. She needs no introduction. She's the inspiration to all of us. She's the ex-HOD and Dean KG Medical University. Welcome you, ma'am. We also have Dr. Sadhna Gupta ma'am, who's the FOGSI leader, iconic FOGSI leader, and she's also the president of NIGEVF. She's a co-chair, CEFOG NCD committee, president, North India Gynecologist Forum. Welcome you, ma'am. As panelists, we have a galaxy of academicians with us. To name it, Dr. Neetu Singh, who's the professor, Department of Obs and Gynae, Ram Manohar Institute of Medical Sciences, Lucknow. Dr. Asma Nigar, professor, Department of OBGYN, IMSR. Dr. Sangeeta Yadav, additional professor, SDBGMS, Lucknow. Dr. APLA Priyadarshini, assistant professor, Obs and Gynae, AIIMS, Raebareli. Dr. Vaishali Jain, HOD, Senior Consultant, Vivekanand Polyclinic Institute of Medical Sciences, Lucknow, and Dr. Nitika Gar, Director, Shivam Care Center, Aligarh. I welcome you all on this forum, and I wish we are going to have a great academic piece today. So now I request Dr. Uma Singh ma'am to kindly introduce and invite our speaker and moderator.
So I hope I'm audible now. Am I audible?
Yeah, ma'am. Yeah, ma'am.
Yes, ma'am.
Okay. So it gives me great pleasure to be present, first of all, this afternoon in this wonderful CME, which rightly said serves as a master class. So it is great to be present here. The topic is very relevant and is an enigma for many obstetricians, and especially those dealing in ART often face these challenges because somewhere in the background there are common things which are between APLA and infertility also at places. So it is a great pleasure for me to invite Dr. Amita Jain. Dear Dr. Amita Agarwal is a professor and heading the Department of Clinical Immunology and Rheumatology at SGPGI Lucknow. She's a great clinician, is a scientist, and her major interest is in the field of juvenile arthritis and SLE, and thereby APLA in pregnancy would be something which we would love to hear from her. Apart from this, she has got great credential in the form of authoring more than 350 articles in international journals, books, book chapters, and having delivered a lot of orations and award-winning papers. A great pleasure for us to have you, Dr. Amita, delivering a pertinent topic. Unfortunately, I don't see the topic, so I think I would invite you to yourself tell us what you are going to speak on exactly the topic. Pleasure once again, looking forward to attending the whole webinar. Thank you, dear friends.
Thank you, Dr. Uma and Dr. Manjusha for inviting me and obviously the whole team. And it's always a pleasure to talk on interdisciplinary areas where we can interact and hear views from each side. Nothing is correct in medicine. It's all that what we think is in the best interest of patients. So what I'm going to talk today, if I can share my slides, is basically I'm going to deal with antiphospholipid syndrome and pregnancy. So there are many issues in it. So what I have done that at the end of this, we will know in different clinical scenarios how we should manage the patient. Because our prime job, whatever said and done, we might do research, we might do everything. Finally, it is, can we bring smile to a patient's life? So my whole thing will be just focused on patients. So let's see this first case. This is a 29-year-old lady who had 3 early pregnancy losses. She also has 2 intrauterine deaths at 30 and 32 weeks. She has been investigated already and found to have high titer anticardiolipin antibodies, which are persistent over a period of time. She also has IgM antibodies, which are of moderate level. She has anti-beta 2 GPI antibodies, which are also positive, more than 99 centile of normal. She has lupus anticoagulant, which is also persistent, but she has no history suggestive of lupus, Sjogren's syndrome, thrombocytopenia, or any vascular thrombosis in the past. Now she has come to you that she wants to conceive again. What advice would you like to give such a patient? Would anybody like to give their thoughts on what advice would they like to give?
Hello. Ma'am, this patient clearly fits into the antiphospholipid syndrome because to all the parameters, the clinical parameter also fits. She had 3 early pregnancy losses and 2 IUDs at 30 to 32 weeks, and her antibodies are also high. So she's in a case of obstetric antiphospholipid syndrome. And so before conceiving, we have to rule out APS is there, and we have to rule out the other causes also. And if she wants to conceive, we have to advise her for going for low dose aspirin. We have to start her on low dose aspirin, and then she can undergo conception. And we have to do other hormonal profile, like we have to rule out the blood sugar levels, the thyroid levels, and this.
Yeah, so this is a garden variety patient of obstetric APS. I mean, nobody would have any doubt in thinking that this patient qualifies to be called as obstetric APS, and she has no thrombotic episodes in the past. So if you look at these classification criteria are basically meant for patients to be enrolled in studies, but we do often use them in our routine clinical practice also. So which patient should you test for antiphospholipid antibodies? Is that 1 or more unexplained deaths of a morphologically normal fetus beyond 10 weeks of gestation? So it's a good idea nowadays, because ultrasound has come, we can look at the morphology much better. So even if it is documented by ultrasound, it's fine. The baby had a normal morphology and had death beyond 10 weeks. Or if you have premature birth before 34 weeks because of eclampsia or severe preeclampsia, or had uteroplacental insufficiency seen by Doppler studies. because you people do ultrasounds very well. You know how to look at these things much better than me. And then if you have 3 early pregnancy losses before 10 weeks of gestation, but they have to be consecutive, because we know in the first 10 weeks of pregnancy, there are many other causes of fetal loss, much more. And the antibody titers had to be moderate to high. So for ACL, we take values above 40, both for IgG and IgM. And for beta-2 GPI, it should be more than 99 centile of normals. That is why just low titer antibodies are not sufficient. And recently, in the last November 2022, we are having a new classification criteria, which has not yet come out in press, but it is for pregnancy loss, there is not much change. Only thing is that if you have early fetal losses, that is less than 10 weeks, or a fetal death less than 16 weeks, has got a very small score, only a score of 1. If you have fetal death between 16 weeks to 34 weeks without preeclampsia, with severe features, then also it's got a very small score. But if you have any severe preeclampsia, then less than 34 weeks, that gives you a higher weightage. And if you have severe preeclampsia or severe, this one more than for 34 weeks, then it is score of 4. So this scoring system is coming because otherwise we are over diagnosing patients with APS, while the therapies may or may not be useful in those situations. But this is still a point which is under discussion. So what is the impact of antiphospholipid antibodies on our pregnancy outcomes? If you see here, that definitely it reduces the live births. So the number of live births reduces. The preeclampsia rates are higher in patients who have lupus anticoagulant or who have triple positivity, like this lady. She has anti-beta-2 GPI antibodies, she has cardiolipin antibodies, and she has lupus anticoagulant. So these are the patients who have a high risk profile. That is, they have triple antibodies. So they are the ones which have a higher risk of preeclampsia. These are the individuals who have a higher risk of having small first gestational baby. And they are also the same people who are more likely to have preterm birth. The neonatal mortality is also increased, but it is increased predominantly in people who have thrombotic episodes in the past. That is, they have previous thrombosis. So different antibodies associate with different things, but this is the largest registry which we have of obstetric APS, where 1,000 consecutive patients seen in multiple centers in Europe have been collected. And it's all divided 1/3, 1/3. 1/3 is prematurity, 1/3 is miscarriages in the early less than 10 weeks, 1/3 is fetal loss, and about quarter is stillbirth. Preeclampsia is seen in about a quarter of them, and HELLP syndrome is seen in a very small minority of individuals. If you treat them, actually the live birth rate is very good. It's almost 72%. People had live births. No live birth, that they have multiple pregnancy losses, is about a quarter of people have no live birth at all. They continue to have multiple pregnancy losses. And thrombosis in pregnancy is a very uncommon thing in obstetrical APS. It's seen in only less than 1%. Do you see purpureal thrombosis, that in the 6 weeks after delivery? There also the prevalence is very low, it's about 2%. And do these patients ever go on to develop other autoimmune disease? It's about 5% of them will go on to lupus. As Dr. Uma had said, since I have interest in lupus, I must be having interest in APS, because these two diseases are very close cousins of each other. And 1% of them can evolve to develop ITP. So it's a disease, actually obstetrical APS generally stays true to itself. It generally causes only obstetrical morbidity. So does this antibody profile alter your outcome? So if you look at total live deliveries, lupus anticoagulant, all of them have almost similar effect. But if you look at early pregnancy losses, it is a little bit more if you have dual positivity. Fetal death is seen much less, but it is seen in about 15%. So if you look at composite, all the things taken together, composite pregnancy morbidity, it goes more with lupus anticoagulant. That's why we say lupus anticoagulant has more specificity than other antibodies if present alone. And similarly, this is another paper which looks at single positivity, double positivity, triple positivity. And if you see again that In triple positivity, you generally use low molecular weight heparin, and this one, complicated pregnancies are much more common. Almost half of them are likely to have complicated pregnancies. Adverse outcomes are also, adverse pregnancy outcomes are seen in nearly half of them. And even they are the ones who have higher risk of thrombosis. So triple positivity should be a red herring, should get your antenna up, and this patient needs to be monitored very carefully. Then what is our principle of management of these patients? One, we must do a risk stratification. As I said, that if you have multiple positivity or you have triple positivity, you look at other coexistent factors. Does the patient have any other autoimmune disease like lupus? Does the patient have any other cardiovascular factors? Because those are the patients who are at a higher risk of having thrombosis. In India, people generally, ladies don't smoke, so you don't have to tell them about smoking cessation, but it is increasing over time. If they have hypertension, manage their hypertension, diabetes, dyslipidemia, because that also increases the risk of obstetrical morbidity. And they must do regular physical exercise. And you must educate the patient regarding adherence, because it's not easy to take anticoagulation, be it during pregnancy or be it afterwards. So they need to adhere to the therapy. If we don't use generally in obstetrical APS oral anticoagulants, but if a patient is very poor, they can be used in the second trimester. Then you have to educate them about monitoring of their INR. And we will discuss the other issues later. So there are many therapies which have been used in obstetrical APS. As you all must be aware that the maximum amount of studies have been comparing aspirin with aspirin plus low molecular weight heparin. And there are studies which compare, older studies, much older, where people used to compare aspirin plus immunosuppressive drug like prednisolone with aspirin plus low molecular weight heparin, or only with heparin. And then we have some studies which have looked at IVIG, the standard heparin, and combination of all the three things. We will see which one is the most useful. So this is their overall efficacy. Of all these studies, if you see aspirin plus low molecular weight heparin actually performs better than aspirin plus prednisolone, it is better than IVIG, it is better than alone prednisolone, it is better than aspirin, and obviously it is better than placebo. So this is the standard of care of using aspirin plus low molecular weight heparin. If you compare it with just low molecular weight heparin, even there, this one performs, this is supposed to be similar, but there is still some benefit when you use aspirin plus low molecular weight. So in this lady, the guidelines are that in a woman who has history of obstetric APS without any prior thrombotic event, with or without lupus, she has no lupus, and has this, the combination treatment with low dose aspirin plus heparin at prophylactic dose, not at the full heparinization dose, is recommended during pregnancy. So this is validated by multiple studies. So in this patient, this would be our treatment of choice. That is using low dose aspirin plus heparin. Like if you're using your enoxaparin, then you can use 0.4 units per kg. So generally we use low molecular weight heparin because it does not cross the placenta. It can be transferred to the breast milk, but not, does not, it is recommended in pregnancy, it is recommended for use in breastfeeding. Only if a patient is very poor, at that stage in second trimester, as we use for heart disease patients, we can use oral anticoagulants. But otherwise, we would prefer to use low molecular weight heparin. The other thing which can be used is a standard dose, standard heparin, which is unfractionated heparin. If you're using prophylactic dose, then you have to use 5,000 units subcutaneous twice daily. So now we have another scenario. This is a 25-year-old lady who is a primea gravida, who has come to you for a routine checkup. And you find that somebody has done this test. It shows that IgG anticardiolipin antibodies are 40 GPL, that is moderate positivity. She has IgM anticardiolipins of 10 MPL units. Her beta-2 GPI antibodies are normal. Her lupus anticoagulant is negative. She is very concerned because this has been made bold by the person who has done the lab test. So what would you do to her? Anybody wants to?
Ma'am, she is asymptomatic. Has
Yes,
a
she's
positive
asymptomatic.
profile that is in the category of low to medium. Hello,
Yes.
ma'am. Am I audible?
Yes,
Ma'am,
yes.
she is in the category of medium risk profile low to medium risk. So
Mhm.
we will not give. We will do preconceptual counseling,
Mhm.
and low dose aspirin can be started uh, with or without prophylactic dose of heparin.
Okay. So your opinion is that you may or may not give heparin, but you should give low dose aspirin. Okay, so let's see.
Yes, ma'am.
First is, should you ever test a primi gravida who does not have any autoimmune disease,
Yes.
who has no history of
No,
thrombosis?
no.
So this is a very
No.
large population-based study to show that APS, antiphospholipid syndrome prevalence is only 50 per 100,000.
Around 2%.
And this is estimated prevalence. So it's very low. So routine screening is not recommended. It gives you more red herring than to give you any benefit. Then should you treat her with aspirin? So this is a meta-analysis which has appeared in 2015. Where 5 studies were done in these women who were just found to be having asymptomatic, no prior history, just antibodies. And if you look at their live birth rate in people who got aspirin versus who got no treatment, there is no difference at all. Even the overall pregnancy complications were no different. So what they have concluded is that prophylactic treatment with aspirin is not superior to placebo to prevent pregnancy complication in asymptomatic APL carriers. But if you look at the EULAR recommendation, what they say is in a women with high risk APL profile, with this lady is not high risk profile because she is neither having lupus anticoagulant nor does she have triple positivity, and she has only moderate elevation, and she has no history of thrombosis or any pregnancy complication. The treatment with low dose aspiration during pregnancy should be considered. So they think only if it is high risk, then only we should consider aspirin. Otherwise, even aspirin is not recommended. So based on the literature, actually, if you see this is, should you treat her with aspirin? This is another group. The high risk profile we say when you, on 2 occasions, she has only one time testing.
Yeah, and ma'am,
Either
that
she
too
has
that
very
too only
moderate
one value.
positivity.
Yeah.
So in her case, actually, there is no indication of even giving any therapy at all. So we need to allay her fear that these kind of antibody positivity is common. The chance that you will have any untoward outcome is very, very low. And there is no recommendation of using any therapy at this time. That is what is the literature tells us. But I know that almost invariably these patients are being put on aspirin. A lot of them also receive low molecular weight heparin.
Can I add, Dr. Amita here?
Yes,
Little
sure,
bit,
sure.
two things. One thing about the first case, that is IUD. So I will say from my side that if it is that positivity, 2 things as a OB-GYN, which actually is a very common practice, that we give progesterone to all high risk pregnancy and we give a rest. That is overall, like as a specialist, you are focusing only on that this triple positivity. Yeah. But when there is a bad obstacle history, 2 things, that is the rest and that is the progesterone supplementation. So a little bit guard about it, that both can like add on to the thrombosis thing, and we have to be very balanced about it. And secondly, this testing in the primi gravida, actually, when first of all, it is not at all indicated. Secondly, I think this is the time, like because primi gravida is always an untested horse, be it a labor, be it anything pregnancy. So in a clinical setting, I think this is the time when our country is having that so much of non-communicable disease, any history of thrombosis, stroke in the family, any history of migraine or dyslipidemia, so that we can really take a thing that something is happening in the family history. And secondly, this when we have it is a APLA positive without no history, then aspirin is the thing which is not indicated. But what we say that it is an uncertain guideline, and aspirin is sometimes we say that it is a aspirin, but every primi gravida is a high risk patient. So it is a gray area actually, and we like to that you say it is no, but our settings say that if especially I will say that we must be careful about the history which is suggestive, if at all we get any testing about it, though we don't do. So your comment about it as a special, like
so what we do is, The family history positivity is actually not a great thing. You should try to see, does this patient have hypertension? Does this patient have any pre-diabetes? You do a hemoglobin A1C levels. You ask the patient in detail about history of any previous thrombosis and other non-criteria features of APS like livedo reticularis, any other features which may suggest that patient has some vascular involvement or not. If patient has nothing, and patient has only one single antibody positive in a moderate titer, then we tell them that actually aspirin is not indicated. It has not shown any benefit, but if you want to take it, aspirin has very little side effects, especially in a young female. The chance of having bleeding or anything is low. So the decision, if you want to take it, the harm is less. There is a minimal harm. Any drug can cause side effects. So, but based on the data, there is no evidence that it will do you any benefit. So this is how we counsel. After we have taken a detailed history, done this, and we tell them. But if a patient has triple positivity and high risk profile of any of these, we tell them that you must take aspirin. Okay, so let's move to the next case. So this is another patient who's 6 weeks pregnant. She has already had 2 first trimester abortions at 8 weeks. She's very concerned because the time is coming. She's already 6 weeks pregnant, and last time she has lost 2 pregnancies at 8 weeks of gestation. Her antibodies are that she has anti-cardiolipin antibody, which is moderate positive, but her beta-2 GPI antibodies are elevated to a good level. But IgM anti-cardiolipin is negative and lupus anticoagulant is not negative. So what would you do for her?
Dr. Neetu, would you like to take this?
Yes. Yes. As ma'am, she is pregnant 6 weeks and history of 2 abortions in earlier and shows these type of investigation. I would like to prefer to give the low dose aspirin along with the heparin, either the this enoxaparin in the dose of 40 milligram OD. So we would like to start these anticoagulants in this patient along with the other therapeutic management for the recurrent pregnancy loss.
Okay, so let's see what's the evidence. This is our feeling. So if you see early loss occurs in about 12 to 13% of clinically recognized pregnancies and 30% in conceptions. Sometimes we don't even know that the person has conceived. The loss occurs in the first 2 weeks itself. So women who are attempting pregnancy, 2 consecutive pregnancy loss occurs in 2%, and 3 consecutive pregnancy loss occurs in 1%. Then this is a study which was done with about 1,155 people. They found that persistent positivity for lupus anticoagulant was seen in 0.5%. And persistent positivity for cardiolipin antibodies was seen again in another 0.5% of patients. We saw that consecutive loss can occur in 1%, 2 losses can occur in 2%. What does APL antibody presence in general cause to abortions? So there is about 2.5-fold increased risk of abortion in individual who has antiphospholipid antibodies as compared to individual who does not have antiphospholipid antibodies. So she has a 2.5-fold increased risk of having this abortion. So now the issues are that she does not fulfill criteria. If we go by criteria, she has no 3 consecutive pregnancy loss. We have seen only one time the antibody level. We don't know if it is persistent or not.
Yes. Yes.
There are no clear guidelines to address these issues because guidelines are generally meant for people who fulfill those criteria. But we can't live by criteria. So some would give only aspirin. Some would like to give combination of heparin, as you said, that I would like to give aspirin plus heparin. So this is a real gray area. That because she has already lost 2 babies early life, and she is concerned, you are concerned. So, and we don't have time to wait for another 12 weeks to repeat this antibodies again. So we have to tell the patient that we have no data, but one group will be that will give you only aspirin because you have a moderate level of 2 antibodies.
Yes, ma'am.
Some group would like to give you heparin, but heparin has these side effects. One, you have to take injection every day. Then there is a risk of osteoporosis. And it's not an easy, and plus the expense. Will it be beneficial or not? We are not clear. So the choice is yours. You want to do it after third pregnancy loss, or you want to do it now? You take your pick. So
Ma'am, here
counseling is
session
very important.
Very important.
Very important. The patient has to weigh the benefits and the risks of taking aspirin. Everybody would like to give. I don't think anybody would hesitate in giving aspirin in this patient. But question of heparin is still debatable.
Ma'am, can I ask one thing, ma'am?
Yeah, sure.
From an obstetrical perspective, what should be the ideal time of starting aspirin? Should it be at the missed period, or should it be started when somebody is even attempting
preconception?
Yeah, so Manusha, if we knew this patient would have been investigated earlier, before she had conceived, then if we had found this antibodies to be positive, we would have done a repeat after 12 weeks and seen that if they are persistent and in this high titers, it would have become more high titers. Or so then we would have told her that you have dual positivity, which is a moderate risk antibody profile. So if you plan to have pregnancy, you can even preconception start aspirin. That is the best. And then heparin choice is with the patient, because there is no clear guidelines in this situation. Should you give heparin or not? So it will be dependent on patient's benefit and risk, what she decides, and then she can take.
Ma'am, suppose we have a tech-savvy patient who has no cost concerns. So in that case, what we practically do is when we document the cardiac activity, that is the time we start with the enoxaparin. So in your opinion, should we do it then, or can we do it earlier as soon as she reports a positive urine pregnancy test?
Because in this case, anyway, we are not sure that heparin will work or not. So in her case, definitely it should be delayed till you have the cardiac activity.
Right.
Because here we are not sure, no?
Right, right.
That it will
Some
be working or
studies
not
say,
working. Yeah.
Some studies say we have to confirm that the pregnancy is intrauterine. Then we can start on, if she's a high risk for APS, obstetric APS, and all the criteria are fulfilled, and we are planning to start the low molecular weight heparin. Then as soon as we are confirmed that it is an intrauterine pregnancy, we can start with the heparin.
So the thing is that she is not high risk.
Yeah, she is not high
That is
risk.
the issue.
We
So
still
that is why
we
I
are
put
in
up
a
this
dilemma
case
whether
that- So here it's a dilemma. Should you be giving or not giving?
Not giving.
So that is
So it's
why
better to wait till cardiac
have the
activity is
cardiac
present,
activity,
and then we can start with.
Then we can start. In this case.
And there's another thing from an obstetrical perspective, like some, especially the IVF pregnancies, the obstetrician is quite concerned that aspirin might cause first trimester bleeds and all that. So I have seen some of the IVF practitioners, especially starting with enoxaparin to start with, and then convert to aspirin at say 10-11 weeks. Is there any logic in such a practice?
We'll come to ART at the end. I've got two scenarios for you for ART. Because so this is the next scenario. So this is a 4 weeks pregnant lady whose last pregnancy she had severe PIH and the baby had intrauterine growth restriction. If you look at her, she has got triple positivity. She's got high titer, moderate titer of cardiolipin antibodies. All of them are IgG and beta-2 GPI and lupus anticoagulant. So what do you do for her?
Yes, ma'am.
Yeah, Nitika, please.
Thank you, ma'am, for the question. Am I audible, ma'am?
Yes, yes.
Yes. Since the patient is in early pregnancy and we are getting the history of severe PIH and IUGR and the anticardiolipin antibodies, IgM is 18, but LA test is positive, which is very much specific for APLA. I think we should definitely counsel the patient, give her the management options, rule out other causes as well to make her pregnancy safe, like her glucose screening test, thyroid antibodies, and HbA1c, everything. And then definitely we will start low dose aspirin in our case. And as soon as the cardiac activity is present, I would keep her on low dose heparin, low molecular weight heparin. but discussing with the patient the cost expenses, and she has to continue it at least up till 36 weeks. So I think that is the option given to her.
Okay.
So, Nitika, would you like to stop LMWH at 36 weeks?
We will discuss that. 36 weeks, should you stop or not?
No.
So we'll talk about that thing also. So this is an analysis of 9 studies where there were 741 individuals in which patients were initially selected because they had preeclampsia. So out of them, what they found was that about 18% of these women with severe preeclampsia had moderate to high levels of antiphospholipid antibodies. So there is a very good association between antiphospholipid antibodies and preeclampsia. So patients who have severe preeclampsia or eclampsia must be tested for antiphospholipid antibodies. That is the first message. If you don't have any other cause, like patient doesn't have renal disease, patient is not having nephritis because of other causes, then you must test. And this is the chance that the patient is likely to have pregnancy-induced hypertension when a patient has antiphospholipid antibodies. It's about 2-fold increased. But the severity is higher in them. They generally get severe PAIH. And this is another one based on which antibody goes with what. So as somebody said, ma'am who answered just now, that lupus anticoagulant positivity is a very good risk factor for having preeclampsia. That has actually the highest odds ratios. And same way is the triple positivity. So this lady has triple positivity. So her risk of having preeclampsia is at least 2.5-fold as compared to the general population. And we saw that she had also growth restriction. So growth restriction is also more in individuals who have lupus anticoagulant or who have triple positivity. So why does preeclampsia occur in these people? So what happens is that when you have antiphospholipid syndrome, you get more death of these cells which form the trophoblast. And there is a less invasiveness of the trophoblast. And plus, in addition, because these are antiphospholipid antibodies, so they bind to all the cells. All our cells are lined by the cell membrane, which contains phospholipid. So all these cells get activated. The platelet is activated, the endothelial cells is activated. So all this leads on to basically more vascular resistance, more, sometimes there can be coagulation, thrombosis there, microthrombi. So that all leads on to preeclampsia. And also there is defects in the coagulation pathway, the fibrinolysis, the small thrombi which form don't lyse. So, and this is basically a self-perpetuating thing. And that is why you get severe preeclampsia in individuals who have antiphospholipid antibodies. And we talked of growth restriction, how much it is. So how do you manage them? So this was a fruit RCT study where they had these patients who had preeclampsia. So they had given them either dalteparin plus aspirin or only aspirin. What do you see here? Is there any difference? No difference was found in this study. That should you give aspirin or these. So this study was actually a negative study. But what the guidelines are, that with a history of delivery of less than 34 weeks gestation due to eclampsia or severe preeclampsia or due to recognized features of placental insufficiency, there is still not very clear, should you treat them with only low dose aspirin or low dose aspirin plus heparin as prophylactic dose. So that you have to see with individual risk profile, what you would like to do. Would you like to give it with heparin or would you like to give only aspirin? So the data is not yet absolutely clear. So this is the only randomized control trial I could find in this situation. So, but most people are still using low dose aspirin plus heparin for such patients because it's a serious illness. So I would like to have your opinion. What do you think?
Ma'am, as
Yes.
per her, ma'am, as per her past obstetric history, severe preeclampsia, and the level of the antibodies, I would like to start aspirin along with the therapeutic dose of enoxaparin. That is 1 milligram per kg of body weight 12 hourly.
Therapeutic heparin is not recommended.
Ma'am, we'll go for prophylactic.
It is only plus and minus prophylactic heparin.
Ma'am, she's triple positive.
Yes.
And her lupus is also positive. So I will go for a low molecular weight heparin in a prophylactic dose. And I will continue postpartum also.
Yes, we will talk of postpartum. Always we continue postpartum for 6 weeks. Always.
Yeah.
So in her case, because she's triple positive, so a lot of people would like to give her heparin. They would like to give low dose aspirin plus prophylactic doses of heparin, which is 0.4, 40 units.
24 hours.
Therapeutic dose is not recommended. But even if you give only aspirin, that also you can justify. That is what I'm trying to say. That if a patient does not want to take heparin, you can be with her. You can tell her that we are not absolutely clear. Your decision may be correct. So never negate what the patient wants, because we don't have evidence. So you can tell the patient, fine, if you want to take aspirin, it is okay. But you tell her that you have a triple antibody positive. You had severe PIH with IUGR. So we feel looking at that triple positivity is a high risk profile. We would like that you take him.
Ma'am, I
Okay,
have a
Nitika.
question.
Yes, Nitika.
Yes, ma'am. I'm going to operate a patient tomorrow morning with a similar history, absolutely similar history, with history of severe preeclampsia, and the patient is at present 36 plus 2 weeks. But since her sister delivered 10 days back and she landed up in IUD somewhere else, she is so anxious that she asked me to terminate the pregnancy right now, and she's on heparin, a low molecular weight heparin, low dose aspirin and everything. She is on labetalol 200 milligram thrice daily, and we covered her. No, betnisol we did not give, dexamethasone or betnisol. But now she is insisting that now you just I don't want to continue. So what should be our counseling mode? Because I want to continue her till 38 weeks. But now she's so anxious, her BP increases every day. She comes every third to fourth day, that now movements are less. Now this.
So this is anxiety neurosis. So anxiety neurosis needs treatment, because you can't, because in today's world, pregnancy is a very precious thing. People are not getting pregnant often. So people want that the first pregnancy should be successful. And if you have a poor outcome in your family, they're very concerned. So our counseling has to be very, very guarded and talk to them. So you have to tell her that does not mean that what happened to your sister is going to happen to you. You are in safe hand. But if you look at her profile, what you said, it means that her hypertension is severe. She's requiring 600 milligram of labetalol, which is not a low dose.
Yes.
Despite that, because of her anxiety, her blood pressure is going up.
I think, ma'am, we should go for an ultrasound.
If her baby is not growing, suppose baby's growth is not happening, then you would like to terminate.
We should go for an ultrasound and Doppler, and we should look for the fluid.
What is the placental sufficiency?
Yes, that's right. We have got
and I think I suggest you should give her. Although she's 36 weeks, but I would suggest you should give her corticosteroids also. What is the
Ma'am, color Doppler has been done. That is all normal. CP ratio and everything has been done. That is all absolutely normal.
If you are planning to terminate, then you need to cover her with corticosteroids. Ma'am,
what is your take on this? Because
I think we're debating from the point about the timing of delivering these ladies. So we can do it in another session.
Yes, I'm not the best person.
One thing Dr. Amita will say that preeclampsia is a very big issue. So what is our recommendation? First of all, yes, it is history of preeclampsia, then it's fine, we do APLA testing. But in the management of preeclampsia per se, actually our bodies, be it a Western, be it a Indian Foxy, that it does not recommend any testing for in the current pregnancy, what we can say for the APLA. It is not in our management profile. And secondly, that we also don't recommend in the present pregnancy that it is a particularly that heparin is not recommended for the management of preeclampsia. So we have to differentiate between the two things actually. When we say that, and rightly you say heparin is not, but if the triple positivity, what we can say, yes, this is the another drug might give you a protection. And to all, we are too much for the heparin, but it has got its own issue. So overall, like not be focused only into the lab values of APLA, but the calcium and the watch on platelet count, watch on the maybe the neonatal complication. We have the heparin. So heparin is still not the drug which we can give like so often, and it is all your very, very good studies says that we are actually doubt. There is no inconsistent and the clear recommendation.
Absolutely, absolutely. So that's what I'm saying, that if the patient chooses to take aspirin, be with her. Say that maybe you made the right choice. So it's not that to force everybody to take heparin.
Ma'am, would you recommend 75 or 150 milligrams of aspirin in these cases?
You can take anything. Both of them work similar. 75 to 100 milligram is fine. That's what is a low dose heparin, a low dose aspirin. Okay, so let's go to this case. This is a different. Yes, any question?
Yeah, ma'am, I have a question.
Yeah.
Madam, shall we screen every patient of severe preeclampsia with APLA APS antibodies?
No. What I said that after you excluded the routine causes, after you excluded other causes, patient may have family history of hypertension, patient already had pre-existing hypertension, patient had a renal disease, patient had proteinuria because of some other disease. All the routine causes have to be excluded. Once you have excluded those, then you test for APL. Not every Tom, Dick and Harry you will test. No.
Yeah, sorry to interrupt, ma'am. I have a question. Ma'am,
Yes.
nowadays, since we are having many of the frozen IVF transfers, and in such pregnancies, we quite often deal with preeclampsia. And whenever we are going in for an ultrasound and risk estimation for preeclampsia testing, which we do around 12 weeks, so quite often we see that the PI is increased and they are at high risk for preeclampsia. So looking into the fact that they are such precious pregnancies and many medical legal issues involved, should we go in for APLA's testing in such cases?
No. You can't prophylactically test for APLA. What I'm saying is if the patient had a previous pregnancy with severe PIH associated with growth restriction, those are the people where you have excluded the common causes, then you test. It's a small group. It's not that everybody beforehand, before the patient has developed any preeclampsia, we will start testing. No. That is not recommended anywhere.
And is there any role of APLA screening in recurrent implantation failure?
I'll come to that. I'll just talk about the ART later. So let's see this case. Okay, so this is a 28-year-old lady who is 6 weeks pregnant. She has a past history of DVT at the age of 26, that is 2 years ago. At that time, she was diagnosed to have antiphospholipid syndrome, and she's been on warfarin. Her platelet count is 1.2 lakhs. Her hemoglobin is 9 grams. She has anticardiolipin antibodies, high titer. She has got moderate titer and high titers of IgM anticardiolipin and lupus anticoagulant positive. So she is dual antibody positive. What would you do for her now?
Can I ask Dr. Sangeeta to please take the question?
Yeah, ma'am. So this patient belongs to a high risk class because she has a previous history of thrombosis with high titers of antibody positive with LA positive. So I would like to give her anticoagulation along with aspirin in this pregnancy. So I will start her on aspirin, and since she is 6 weeks pregnant, and this is the period of organogenesis. So I would like to switch over her from warfarin to low molecular weight heparin in therapeutic dose. So that will be 1 milligram per kg body weight BD. So that I will
this
start.
is the indication for therapeutic dose of heparin. A patient who has previous thrombosis must receive therapeutic doses of heparin, not prophylactic doses. So if a patient, this is a patient who has, so you will give a low dose aspirin and heparin at therapeutic doses during pregnancy. Only thing is that you should, ideally before the 6th week, that you should change to as soon as the pregnancy is confirmed, as Sangeeta said, that we want to avoid the teratogenic effect of warfarin. So as soon as you confirm pregnancy test is positive, you switch over. And preferably before 6 weeks. She has come to you at 6 weeks, so you switch it over as early as possible. Stop her thing. So in this, there is no doubt. There is no if and buts. The treatment is very clear. You need to give full dose heparin. So now this is a patient who has who's been diagnosed to have obstetric APS. She has 2 fetal losses at 30 to 34 weeks, despite being 2 times on low molecular weight heparin and aspirin. She has taken very sincerely all throughout pregnancy. She still lost those 2 babies. And she's currently taking aspirin in a prophylactic dose. And she is on hydroxychloroquine also. Somebody has put her on hydroxychloroquine. She has no living issues. What are the options available to her in next pregnancy? She's come to you. She has lost many babies. We previously had abortions. Then she had 2 fetal loss despite getting treated, diagnosed. What would you do? Tell her. What are the options to her?
I think, ma'am, this time I would like to monitor. I would like to monitor this pregnancy very closely, because in spite of aspirin and low molecular weight heparin, if she's losing, and then regarding HCQ and other options of treatment, there are no clear-cut guidelines. And still trials are going on. So it is not a wise idea to start her on the other therapies like IVIG, prednisolone. The trials are still going on. So I would like to look for other causes also which can lead to fetal loss at this gestation. So I would like to see her blood sugars. I would like to monitor the pregnancy very closely, seeing her liquor, growth, Dopplers, everything very carefully.
She has had all that done in the last 2 pregnancies. Everything done. Everything was monitored. She's non-diabetic. She's non-hypertensive. She is very concerned now what to do. Should she have another pregnancy or not? That's the first issue. If she has, what will you do for her?
Then she should be given aspirin along with low molecular weight heparin in a higher doses, I think.
Okay, so that's one option. You are saying she should be given therapeutic doses of heparin.
Yes.
That is one option.
I think we should rule out hereditary thrombophilias as well in such cases.
Hereditary thrombophilias. In hereditary thrombophilias, what is the treatment?
Still debatable. Still debatable. A lot of debate that actually they should be given heparin. Aspirin, okay. And you have actually specifically put the question for HCQ. So HCQ can be like this case when we have done LMWH aspirin and they had, and we know that it was something related to IUGR or thrombosis. HCQ has been proposed as a good addition. If the patient is having other autoimmune disorder, then it is fine, and even with the history, because in the this is a drug which we can think of actually, and few studies actually say that it is a simple also, it is not as costly also, and safe also, safety profile is there. So I will think for SCQ at least, definitely.
Okay, so this is what the guidelines for us are. That in women with criteria of obstetric APS with recurrent pregnancy complication, despite giving this combination of low dose aspirin plus heparin and prophylactic doses, we have many options. All of you have talked of those options. One is increasing the heparin dose to a therapeutic dose. Second is you can add hydroxychloroquine. Third is you can add low dose prednisolone in the first trimester, may be considered. And use of IVIG might be considered in highly selected cases, but the evidence is very poor for IVIG. The trial which was done for IVIG did not show any benefit. It's an expensive therapy given every month, 1 gram given every month, but it did not result in increased pregnancy, better pregnancy outcome as compared to people who did not receive it. So IVIG in our country should be absolute no-no. Only reason could be that if a patient has thrombocytopenia in association with APS, that is an indication of giving IVIG. Otherwise, IVIG should not be used indiscriminately.
I thank you, Dr. Amita, for this wonderful message. A great thanks on my part, because we really struggle for so many glamorous people that I really owe a big thank for this clear message.
Just a question, ma'am. Just a question, ma'am. Should we stop prednisolone in the second trimester then?
Yes, because people say that because the risk-benefit ratio, what people have shown is when you continue prednisolone in the second and third trimester, the chances of complication related to prednisolone therapy come in. So that is what, because there is no evidence. Actually, we have very little evidence how we should be treating. It's only by case series or by very small trials. So that is why if you look at the level of evidence, it is 4 and 5. very poor evidence. So these are the options available. Either you're using full dose of heparin, adding hydroxychloroquine, as somebody said, is the best option. It's very cheap, safe, effective.
And ma'am, how much dose of hydroxychloroquine should we give? The
5
dose of
milligram per kg. 5
hydroxychloroquine,
milligram
ma'am.
per kg to a maximum of 400 milligrams.
Okay.
And it can be given throughout the pregnancy. It has very good effect. It has good effects on lipids. It has effect on the endothelial cells. It also reduces the thrombosis risk. So that is why hydroxychloroquine is, and plus there is another mechanism of acting on the neutrophils, reducing netosis, causes better placentation and other things. Okay, so this is what people say for refractory APS. This is guidelines given by somebody. So you have done that, prophylactic, then you can use hydroxychloroquine because it's the safest. Next step can be, suppose still the pregnancy loss occurs, you can use a low dose aspirin and prednisolone, 10 to 15 milligram per day, or you can increase the low molecular weight heparin to the therapeutic dose. People say people have used to do IVIGs and plasma exchange. There are some case reports where people have even given anti-TNF agents. People have given many things, and then statins. So I will just discuss this study, the last study, the statin one, which is a very interesting study. This is published in 2016. So they had 21 pregnant women who developed preeclampsia and or IUGR, even when they were treated with low dose aspirin and low molecular weight heparin. So what they did was they took these 21 women and divided them into 2 groups. 10 patients they again gave in the next pregnancy low dose aspirin plus low molecular weight heparin, and in 11 patients they gave pravastatin, which is a hydrophilic statins, in addition to their low dose aspirin and low molecular weight heparin. And what happened? In control group, all deliveries occurred preterm, and only 6 of the 11 neonates survived. While in this, all the pregnancies reached near term, from 34 weeks to 38 weeks, and all the fetuses survived. I mean, all the babies, they were live births. So it's a very dramatic study. But we have to see the replication that does it really hold true of pravastatin. So it's done in a small number of individuals. So this is the mechanism of action. It's been done only in people who had PIH. So it basically causes increase in the nitric oxide, so causes vasodilatation. And that leads on to increased placental flow. It doesn't cross the placenta, so it doesn't have any bad effect on the baby. That is why they've used pravastatin and not the other statins. And it has shown that this is your pressures which you measure, placental uterine artery pressures, I think, whatever it is called, PI. So that has dramatically reduced in people who got pravastatin. So this is one of the possible therapies for future. So now we have this patient. I don't know how much time we have, Mandusha.
It's all right, ma'am.
It's okay?
Yes, ma'am.
Okay. So this is
Really a pleasure. It is really a pleasure to go through each of these cases in such immense in-depth, I mean.
So this is a 29-year-old lady whom we saw, who has already had 3 first trimester abortions, but there was no history of any thrombotic event in the past. She was 14 weeks pregnant when she came to us. She had ANA positivity. She had triple positivity for antiphospholipid antibodies. So there was no doubt in diagnosing her as primary APS. She had no other features of lupus. So we gave her hydroxychloroquine because she was ANA positive, and we generally like to give hydroxychloroquine. She was given calcium, vitamin D, folate, aspirin, plus low molecular weight heparin. And then she was lost to follow-up because of COVID lockdown after this 32 weeks. She came to us at 14 weeks, and 32 weeks later, she had a normal delivery at 38 weeks. She presented to us about 4 weeks or 6 weeks postpartum to the emergency with shortness of breath and pleuritic chest pain for 2 days. A CT angio was done at that time, and she had actually a right pulmonary embolism. And she also had a left lower limb DVT. What do you think could have happened? What we just heard somebody was saying, no?
Pulmonary embolism.
And a left lower limb DVT.
Yeah,
Even though she
DVT.
has no past history of thrombotic event. So we need to continue heparin for 6
Until
weeks after
postpartum.
delivery.
Yeah.
So in this patient, because of the COVID pandemic, wherever she delivered, immediately after delivery, the heparin was stopped. So all patients whom we are giving this must continue heparin at least for 6 weeks after delivery. This is to reduce the risk of maternal thrombosis, because postpartum period is a prothrombotic stage. And if you stop this, patients can have this kind of a catastrophic event. So always give heparin. If you're giving heparin during pregnancy, give it for 6 more weeks. Then this is, I have just 2 cases on the ART part. So this is a patient who has,
Dr.
yes.
Amita, I will just like to,
Yeah.
it is, I am Dr. Sadhana Gupta. So
Yes.
I want, this is postpartum prophylaxis. Can we switch again to warfarin in the postpartum period, make it convenient, or we have to continue with the same element?
Continue heparin, that's best, because you're going to give it only for 6 weeks. It's changing over because it's not easy. You have to titrate. It takes about a week. And then person to get INR done very regularly in a postpartum period is not easy. And if they've taken for 9 months, they don't mind taking for 6 weeks more.
Okay, fine.
So that's much easier. They're used to it. They find it much easier to take that than to switch over to warfarin. But if a patient is very poor, definitely we switch it over. Okay, so this is a patient who has secondary infertility. She's already been diagnosed to have obstetric APS. She wants to undergo IVF now. What would you advise to her? Because she's having recurrent pregnancy loss, so it took her a long time. Now she's 36. She's not able to conceive.
Can I ask Dr. Vaida to take this question? Dr. Vaida, can you please take this question? Dr. Vaida. Or else, can I ask Dr. APLA?
Yeah, ma'am, since she is in the preconception period, so we should start with low dose aspirin for her. And we should also consider pre-implantation genetic diagnosis or embryo screening to rule out to any aneuploidies, because they may also be a cause of recurrent pregnancy failure.
Okay. So when you will do ovum pickup, would you do anything else for her?
Ma'am, mind block हो रहा है इसमें आपको ही बताना पड़ेगा.
It's exactly a mind block because even we have not on this.
So patient with positive APL or APS should receive anticoagulation at the doses as would be recommended during pregnancy and or low dose aspirin. So you must give these patients the same kind of therapy. And it's, if you are going to do any procedure, if patient is taking low molecular weight heparin, you should, so like if patient is already taking, you said you will give prophylactic. So low dose aspirin should be stopped 3 days before the retrieval and resumed the following day. If patient has got thrombotic APS, like this lady has obstetrical APS, so she's not on anticoagulation. But if a patient is on anticoagulation, if patient is taking low molecular weight heparin, you should stop at least 12 hours prior to the procedure and resume it on the same day, because we don't want to give any risk of thrombosis. And
but usually, ma'am, if they are on warfarin, like
if they are on warfarin,
thrombotic
you change them over to
events,
low molecular weight heparin.
Okay.
And then you stop it 12 hours prior to it. And patients who are just positive APL, who are not taking any low dose aspirin during the ovarian stimulation period, you should start them on low dose aspirin, because that increases the risk of thrombosis. Because when you do ovarian stimulation, you're giving hormones to patients. Those can cause prothrombotic state. So you start LDA on the day of embryo transfer, usually in combination with low molecular weight heparin, when you do the embryo transfer.
Actually, this is a really gray area, because we really give so much of progesterone and estrogen, and like at the, so it is not something like we have to make clear that it is risky, like it is a risk factor for the IVF as well. So, and we have to be very careful that we don't like actually do the whatever is needed and not the extra progesterone, because that is very important. And very nicely, and like I also give aspirin and the like LMWH up to the inside pickup. So progesterone is something which is really worrying me with listening to.
Yeah, because ovarian stimulation is a really prothrombotic state.
Yes.
And the thing is that tell the patient that your chance of success is absolutely similar to general population. That's why I said that how you counsel, that it doesn't matter you have obstetric APS, but your chance of conceiving with IVF is as similar to as anybody else. But because you have obstetric APS, so we have to give you anticoagulation, low dose aspirin for during the procedure as well as during the pregnancy.
Yeah, ma'am. Actually, I just missed a part of the discussion.
Yeah.
Ma'am, do you mean to say that this is not associated with any way to recurrent implantation failure?
We are coming to recurrent implantation. Just next is, does APL have any role in IVF failure? What does it show? So this is a systematic review and a meta-analysis of 17 studies. And it showed a high degree of variability in APL positive in recurrent implantation too. So it's really not clear, because if you see at risk, there is not much difference. So among the criteria, APL, IgG, cardiolipin antibody was little bit associated with recurrent implantation failure, while the non-criteria antibody like those IgA and those other ones, they had some risk. So what it is said is that anticardiolipin IgG is prevalent in women who have recurrent implantation failure. The three other are also present in some people. Overall, these results advise about testing them. That you test if you have recurrent in vitro fertilization failure, and if they are there, then you treat as you will treat anybody with antiphospholipid syndrome.
Okay, thank you,
So
ma'am. So one thing more, you were saying that we should start low molecular weight heparin right from the embryo transfer, from the day of the
patient who has obstetric APS, not for this, for obstetric APS. This is testing.
For obstetric APS.
Yes, yes.
And it should be in prophylactic dose only.
Yes.
There is no role of therapeutic.
No role of therapeutic. Therapeutic is only when you have history of thrombosis.
Episode of
thrombosis. Otherwise, there is no indication of therapeutic heparin. The only other indication is if there is a recurrent failure despite prophylactic dose of heparin. Then it is only a trial basis that you can give a full dose heparin along with aspirin. I showed you a case, ma'am, where there was a failure. 2 pregnancies lost despite low molecular weight heparin in a prophylactic dose. There you can think of giving a full dose heparin. Otherwise, not indicated.
Can we add steroids to them? No. Is there any role? Because routinely we have seen that earlier, like people used to give prednisolone in this.
So I said that if you have failures despite low molecular weight heparin and aspirin in a proven case of obstetric APS, you have multiple choices. Out of them, hydroxychloroquine is the safest choice because it is cheap, effective, and safe.
Yeah.
Next, you can use low dose steroids. You can use full dose heparin, that is therapeutic doses of heparin. And I showed you a study on pravastatin. IVIG should be avoided because it doesn't give you any benefit, very expensive. So the last is the contraception.
Role of PGT, like any role of PGT if the patient is having in such a patient with obstetric.
What is PGT? I don't understand your abbreviations. What is
like
PGT?
Pre-implantation genetic. Actually, APLA,
I have no idea.
mentioned it, so I was like, I thought that might be she's taking.
No. I have no idea about this. You may be better than me. So the last thing is contraceptive advice. What contraceptive advice should you give?
Ma'am, we should avoid the estrogen containing
Yes.
contraceptives, and best is intrauterine device, which is a copper device, or in some cases we can go for levonorgestrel IUDs also. So these are the options, and we should avoid using estrogen containing contraceptive things.
So levonorgestrel also should be used with caution because it can also increase risk of thrombosis. So you should use, if you need to use pill, then use only progestin pill, only progesterone, which can be subcutaneous depot. But then, as Madam was saying, Dr. Sadhana, that it increases the risk of thrombosis. And plus, these only progestin pills also have a high failure rate as compared to the combination pills. So these are mainly used in adolescents. Like in our country, still now, I don't know how many of adolescents use a contraceptive pill. Abroad, most adolescents want to use pill. So there, when we have to prescribe to a patient with APS who has moderate to high titer, high risk profile, in those patients, you tell them that they should use only, especially patients with lupus who have a this, so you advise only progestin pills to them. And
amongst the progesterone-based methods, the levonorgestrel IUD should be the best choice, I guess, because it only uses
yes, but you don't give it to people who have not been adolescent. You don't give IUDs.
Ma'am, the scenario is changing. Like 80% of adolescents who walk into our clinic are already sexually active. So,
yeah, so you give them IUD. Do they agree to take IUD?
Ma'am, if somebody has something like APL already, we can talk them out into it. And maybe
so abroad, people don't want to take IUD. So wherever I have
Ma'am,
abroad,
IUD, if with contraception, they have some abnormal uterine bleeding in the younger generation, we can counsel them to go for LNG IUCD also. So now, like in India, it is still less, but definitely in abroad, they are using LNG IUCD for various other conditions. And if they are having this positivity, then we can go for LNG IUCDs
yeah,
also.
yeah, definitely. If they agree for IUCD, that's the best. Intrauterine device is the best for patients with APS. If you can't give IUD, then you should use only progestin pills. And also, the only progestin pill which we use for emergency contraception is not contraindicated. So it's a higher dose, but because we are giving it only once, then it is okay. You can use that. And so this is what you should generally avoid these things with combined hormone pills, oral pills, vaginal rings, transdermal patches. All these should be avoided because that increases the risk of thrombosis. So this is what I find here, that people keep on using low molecular weight heparin in unexplained recurrent pregnancy loss. It doesn't do anything unless you have antiphospholipid antibodies in moderate to high titers. But unfortunately, we are stopping more low molecular weight heparin than starting actually. Patients who come to us because they are getting unnecessarily, just with an antibody level of 21, one antibody, they have nothing else. So this is the data. This is also, it's been done in many other countries also. If you look at the data, there is no difference in the pregnancy outcomes in patients who have unexplained recurrent pregnancy loss, even if you use low molecular weight heparin. So please don't use it. There's no significant difference. So this is in summary for you, and we have discussed all the options, so we can leave this. And this is a summary we can have. If any questions, I can take.
There's one question from one of the audience, the delegates, that is more of an obstetrical question rather than this.
Dr. Sudha can take it.
Yes, when the patient is hypertensive, whether we can give aspirin in early pregnancy.
Actually, as per guidelines, if there are few criterias, and if she's a high risk for preeclampsia, then if you are finding at 12 weeks of ultrasound, we are finding the notching and other factors, then we can put her on aspirin, and it should be ideally started before 16 weeks of pregnancy. And the dose is 150 milligram per day of aspirin as a prophylactic dose.
Thank you, Vishali. That was very well said. Ma'am, one more very basic question I would like to put up for the sake of our learners and myself also, as to how far should we go in investigating for the antibodies. The companies come up with many packages, the basic APLA test and the extended APLA test. So if somebody is kind of not affording, what 1 or 2 or 3 tests would you recommend? And if somebody can afford it, how far
if you
should
take 1,000 patients, about 700 of them will have IgG anticardiolipin antibodies. So that is the most sensitive test. If you look at lupus anticoagulant would be positive in about 55 to 60%. So the maximum positivity is of IgG anticardiolipin. Some studies have shown that it is positive even in about 75 to 80% of these. So if you have to do 1 test, that is the best. If you can afford 2, then do IgG anticardiolipin antibodies and lupus anticoagulant. Because if IgG anticardiolipin antibody high titer, like if you find more than 100, it's a very high titer. If lupus anticoagulant is positive, that dual positivity is a high risk positivity. So you have done your job. You don't need to do anything more. Otherwise, do IgG beta 2 glycoprotein 1. So actually, if you see the new revision, there only these three are being given weightage. The IgM, presence of IgM anticardiolipin, IgM beta 2 GPI has got a very poor correlation with either poor pregnancy outcome or with thrombosis. So that is given only a very poor weightage. But if you find that all three are negative, you have done IgG beta 2 GPI, IgG anticardiolipin, and lupus anticoagulant. But the patient history is characteristic. Patient has had multiple pregnancy losses, which fit in with this, that is the prothrombotic state. You have excluded other thrombophilia. Then you can do IgM anticardiolipin, and you can do IgM beta 2 GPI. If you still find that is negative, then some centers would label these patients as seronegative APS. That is, they don't have these conventional 5 antibodies, and these are called seronegative. They may have antibodies to other phospholipids. The one which has been shown to be much more in this population is antibodies to PSPT, that is phosphatidylserine prothrombin complex, or antibodies to annexin 5, which is more relevant for pregnancy losses. But those antibodies are still in the realm of research. So we should not be doing it routinely. If you want to save money, just do 3.
Ma'am, my question is, ma'am, one
Yes.
question, if it is positive, then we have to repeat after 12 weeks. But if the
Yes.
clinical history is very much suggestive of obstetric APS, so should we, if one report is negative, should we repeat it again? Or should we just do one report and say, no, it's not obstetric APS?
So generally, if all the antibodies are negative, it's very unlikely that the patient has APS. Very unlikely that even if you will test after 12 weeks or 3 months or 4 months, would it come? Very unlikely, but it can happen. It's not that, but it is very unlikely. But if those, like you're finding moderate positivity or they are in borderline 30, 20s, then you may repeat it once more. But the risk with low titer is not much, because that could be a transitory antibody. Especially IgM have been shown to be really transitory. It can occur because of viral infections. Because of any infection, IgM antibodies can rise. So if you have only IgM, it means that may not be very great thing. You will repeat and it may come totally negative.
Do we take this as a message that the protein C, the protein S, the antithrombin 3, all these things are not to be done in patients with suspected APLAs?
No, in APS it's not needed. None of them are needed. It is because you people are doing a thrombophilia screen. So that includes a whole panel. But you need to know, if you want to save money for patients, what is the proportion of patients who have pregnancy loss because of protein C deficiency? What is the percentage of people who have lost because of protein S deficiency? It's much, much less than what antiphospholipid syndrome is.
Yeah.
So you can do it in parts. First do rule out APS, which is most common, then rule out the next one. Because patient is at present not pregnant. You are doing it in between. Patient has had a pregnancy loss. So you can do it in a staggered way. Or you do a package deal, do everything. That depends on the approach.
Ma'am, sometimes we advise a patient to go through these antibodies and she happens to conceive in the middle. So are those readings still applicable, or do we ignore them given the fact that
No, they are applicable. All are applicable. Antibodies levels don't change much. That is why we say persistent presence. So because the problem with the phospholipid assays are that they are not as robust. So that is why in this disease, in this antibody, we don't say that if it goes from 20 to 30, it is of any significance. No, we say less than 20, between 10 to 40 is mild elevation, 40 to 80 is moderate elevation, and above 80 is marked elevation. That is high titer. Because these assays can have a lot of variability. The same sample tested in 3 labs may give you totally different values, but it will be in that range. Between 40 and 80, if it is between 40 and 80, it will stay between 40 and 80. If it is above 80, it will give you a reading. It may be 100, 150 in some lab. So that is why this classification has come in. Because phospholipid assays are not assays which are difficult to do.
Ma'am, I have one question.
Yes.
Ma'am, if the APS is associated with the thrombocytopenia significantly, what are the treatment options? Is this same or something different?
No, there is a difference. If like what people have shown, that if at 10 weeks, 10 to 12 weeks, you find thrombocytopenia, it's a very poor prognostic factor. And the second thing is that thrombocytopenia should be treated if it is less than 50,000. Between 50,000 to 1 lakh, it's a debatable issue. Should you treat or should you not? When you treat in pregnancy, if it is during the first trimester, steroids are very good because there is not much side effects of steroids in the first trimester if you're using a 0.5 milligram per kg. Right, because it doesn't affect much of organogenesis except rare association with cleft lip, cleft palate, which is easily treatable condition. So you can use steroids, which is cheap and effective. If it is after that, second trimester or something, then actually the treatment of choice is IVIG. That is the best therapy for looking after thrombocytopenia of APS.
Right. Thank you,
Ma'am,
ma'am.
I have one question regarding low dose aspirin. Ma'am, how much dose do you recommend for low dose aspirin? Because there are variation in doses that is given in the literature.
Yeah, 75 to 100 milligrams. 75 to 100.
75 to 100 milligrams. Or somewhere it is written 81 milligram or somebody.
Yeah, we are not getting it in India.
So the thing is that every country has a different amount available. That is why it is said it can be 75, it can be 82.5, it can be 100. So 75 to 100 is a low dose aspirin because it is that level of aspirin actually gives you an effect of decreasing the platelet aggregate. That is why you're using that much doses. If you use a higher dose, that effect goes off.
And what is about oral anti-factor kidney drugs?
The direct acting anticoagulants?
Yeah.
Yeah, so direct acting anticoagulants actually have been shown to be detrimental in patients with APS. All the three trials, the RAPTAS and the looking at rivaroxaban and epixaban trials had to be stopped in between because there was higher risk of arterial thrombosis in patients with APS. We really don't know the mechanism why they had higher risk of arterial. They had strokes. So it is not recommended. DOACs are not recommended at all for patients with APS.
Ma'am, do you think HCQ will become a first line of drug like in a country like India? Because if it is having same effect as aspirin with low molecular weight heparin?
No, we didn't say that. We said hydroxychloroquine can be added as an adjunct to a patient who has had recurrent pregnancy loss despite being on aspirin plus low molecular weight heparin in a prophylactic dose. So it's only in those patients who have repeated failures despite this standard of care. Only in them hydroxychloroquine can be added on, not replacing that.
So thank you, ma'am. It was an amazing discussion.
Thank you, ma'am.
We have already surpassed the deputed time schedule. So I just request our expert, Dr. Sadhana ma'am, to just conclude with her few words.
I think ma'am is busy. So I have a request from Dr. Manjusha ma'am and Dr. Varda to provide us with the PPT of ma'am so that we can circulate in a group and benefit others also. It's really nice.
Nice.
We have got clear guidelines now, when to start and when to give the therapeutic or the prophylactic dose.
Nitika, PPTs are intellectual copies and we should not be asking them.
Yeah, ma'am. But it was definitely an eye-opener session for all of us.
So knowledgeable and so
exactly.
I think amazing, ma'am. You have an answer to every small little query of ours. It has been really keeping us in a dilemma forever. I mean, I wish we could hear from you over and over again, and it could go on forever. I mean, thank you so much, ma'am. It's so nice to have you with us.
I hope I have been able to do justice because yes,
it's great to have Dr. Amita, and I think we will be needing you much more at various platforms, because actually I'm so happy this evening has been so, because you really put on the emphasis on the unnecessary investigations unnecessary over treatment, and whenever we need. So this is actually the way what the Manjusha said, it is packaged and everybody is confused. And even in the educational program, people are giving confusing messages. So it was a wonderful evening, and we really like to have your association at many platforms. It was really a very good evening. Thank you very much, Dr. Amita.
Thank you. The pleasure is mine. I enjoyed interacting. It's been a great pleasure to learning from you, how you practice and how we do. So thanks a lot.
Thank you, Amita ma'am.
Welcome to send me or send to Manjusha. I can answer those queries in later time.
Yes, ma'am. Thank you,
Thank you,
ma'am.
Sadhana ma'am.
Thank
Thank you,
all
Sadhana
the
ma'am.
speakers, the experts,
you.
the lovely panelists, and not to forget the Shield Pharma Connect, who have provided us this platform to conduct this amazing CME. And we look forward to have more of such academic feast in future. Thank you, all of us. Thank you, Manjusha ma'am.
Thank you, all of you. Thank you.
Thank you, ma'am.